Welcome to Season 14 of The Regimen. Joining us today is URI RAM and local pharmacist Amanda Petrarca for an interesting discussion about the opioid-sparing treatment pathways and how they're being used in medical procedures in Rhode Island. Hello, pharmacists and friends. Today is Friday, June 7th, 2024. Welcome to The Regimen, where public health pharmacists, pharmacy students, and our guests discuss latest public health issues and solutions. Listen in to find out how we can all improve population health, health equity, and patient care through advocacy and education. My name's Liz Arnold. I'm a 6th and final year doctor of pharmacy student at the University of Rhode Island, working alongside Dr. Bratberg in the Rhode Island Department of Health.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in the podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, the University of Rhode Island, nor any of the pharmacy owners mentioned here.
I'd like to start off by introducing Amanda Petrarca, pharmacist and pharmacy manager at a local independent pharmacy, Green Line Apothecary. We've worked together for almost a year and a half now, I think. Thank you so much for joining us today.
Thank you for having me.
Can you tell us a little bit about you and your background?
Sure. I'm a community pharmacist. I've been practicing for about 16 years. I'm a 2008 graduate from the URI College of Pharmacy. I've worked in both Connecticut and Rhode Island throughout that span, and I started my most recent position at Green Line Apothecary in 2022.
Awesome. Thanks. In the midst of an opioid crisis, healthcare professionals all over the country are looking for ways to increase awareness and decrease misuse. Studies have found that orthopedic surgeons are among the highest prescribers of opioids in the United States. With this, a local initiative from a Rhode Island orthopedic practice has begun to address this crisis with an opioid-sparing pathway. Can you tell us a little bit about what this is and the purpose?
I'd love to. The opioid-sparing pathway was a real shift in how we think about pain and how we treat pain in both the preoperative and postoperative interval. Chronic pain associated with orthopedic injuries and conditions is notoriously hard to treat. So that doesn't surprise me that opioids were highly used in the past historically to help relieve some of that pain. What we eventually realized was it really required a multifaceted approach where we saw other medications, anti-inflammatory medications, muscle relaxants, other medications to try to manage the pain, but it wasn't enough often, and it wasn't improving patients' quality of life. So a group of healthcare providers essentially got together and collaborated to find a better way, and to see if we could have a more comprehensive approach to helping patients manage their pain after surgery in particular. We used to use PCA, or patient-controlled analgesia, a very reactive approach to pain where a patient was in charge of their own dose. When they felt they needed pain relief, they were allowed to administer their own dose of typically an opioid-type medication post-surgery. And what they eventually found was it really delayed mobility and recovery, especially for these orthopedic patients, because we wanted them up, we wanted them moving, we wanted to start the recovery process as soon as possible. So the opioid-sparing pathway was kind of designed to acknowledge that there would be some pain associated with this procedure, but that together, working with pharmacists and doctors, surgeons, nurses, physical therapists, we were all going to collaborate, work together to help you manage the pain associated with the procedure. And we found that it was a better way to serve our patients, and they were allowed to participate better in their own recovery.
Thank you. And what are the medications involved, and why have they been specifically selected for use in this pathway?
I'll start by saying that each pack is sort of individualized based on the procedure the patient's having, medications the patient might already be taking, but typically in the pre-surgery pack, you'll see an anti-inflammatory medication that's often started a few days prior to the procedure. This is in an attempt to stop the inflammatory processes before they even start that might be associated with a procedure. There'll also be a neuropathic type medication often included pre-surgery to, again, help with pain relief. Then the day of the procedure, you'll see another analgesic, typically acetaminophen, to help control pain. There'll also be continuation of the anti-inflammatory, a medication, usually tranexamic acid, that will help to improve blood clotting, reduce bleeding and bruising during the procedure, and omeprazole as something to protect your stomach after surgery.
Yeah, and I liked a really great description, and I just want to emphasize a couple things, that all of these procedures are done in collaboration with the patient and their caregiver and the surgeons and everything. People listening should not say, oh, this is a great thing, I have surgery, I should do this. Just make sure this is all a highly collaborative environment.
Correct, yeah. Highly individualized as well.
Yeah.
The doctors take the full patient profile into account, as do we when we're providing our counseling and med reconciliation. So
I think that's important. And then the other thing, I'm happy that you added all of the layperson descriptions of these medications, right? And what they do. The one thing is you talked about neuropathic. I think people misinterpret what that is. Can you talk more about the medicines for neuropathic pain, or how that pain is different? You talked about inflammatory pain and opioids for pain. Can you give a little more about what neuropathic pain is and why we're treating that?
We're often starting to see medications like gabapentin being used as an adjunct therapy to help treat chronic pain conditions.
Okay, thank you.
Working at Greenline, I've spent a lot of time working on the pre-surgery packs, and I have noticed that sometimes they'll come in without the anti-inflammatory or without the tranexamic acid. But I've also seen some come in that have the addition of an antibiotic like erythromycin. What's the purpose of adding those types of medications?
The individual prescriptions that come over really have a lot to do with the type of procedure that's being done. Antibiotics are often used in different types of procedures that might not be ortho-related. It might be more of a GI type procedure where you really want that antibiotic on board. If you're having some sort of bowel resection, or urologists will often use an antibiotic, gynecologists even. So it really depends on the type of procedure that's being done.
Yeah, so really any time that we all have bacteria on our skin, and so when you have any kind of surgery, there's intravenous antibiotics that are given around the surgery just for a day. But this is even more interesting, that if you're accessing parts of the body that have different kinds of bacteria in your skin, you may need different antibiotics. So it's great how individualized this is. And it's interesting for me, when I heard about this, I thought it was just ortho procedures, so it actually goes beyond. You actually have, what percentage of all of these pathways are the orthopedic? I assume that's dominance, or are non-orthopedic.
Yeah, I would say definitely the dominating factors are orthopedic patients, but it's not a novel idea. This ERAS protocol, it's called. It stands for Enhanced Recovery After Surgery. And a lot of institutions are starting to adopt these processes with the idea that if we can make our process uniform, recovery then will follow as being more streamlined, more patient-oriented, and give better results in the long term.
That sounds good. Almost sounds like a protocol. We were talking
Yes.
earlier that it's kind of a protocol, but you talk about standardized yet individualized, which is why I like the term pathway, I think. So
yeah,
it
fits better. And you had mentioned patient counseling earlier, so I know that's a big part of the whole pathway. How do you counsel patients on the packs?
I think that's one of the most rewarding parts of this whole procedure. It's counseling patients is kind of our specialty as community pharmacists. We are essentially educators on the safe and effective use of medications. And there's a lot of apprehension that often comes along with these types of procedures, that we are in a good position to not only explain the reasons behind these medications, but also to give our insight into why we think it's appropriate, offer counseling or advice. The counseling portion is probably what takes the longest out of this as far as the pharmacy is concerned. It's certainly something that we enjoy taking our time and not rushing through with the patient, because we collect important information from them. We want to know what other medications they're taking so we can check for interactions. They're not necessarily always our customers that we're seeing every day. These patients come from all over, so it's important to us to kind of develop that relationship. But also the typical questions that you think of as a pharmacist. How would you rate your pain? What makes it better? What makes it worse? What helps when you're at home? Kind of this more holistic approach to it, so that we're not just acknowledging the pain and giving them a pill to treat it. It's more of taking the whole patient into account. And I think that builds a lot of trust, and it gives them a healthcare provider to come to with questions in the pre-surgery phase, and gives them a lot more confidence going in that this is a decision that they're making for their health.
And just a logistical question, that's all fabulous stuff. And two logistical questions, I guess. Is this a separate appointment that the patient, when they pick up the pack, that they're having like a scheduled appointment with you, or is it they're picking it up and you say, and now it's time to counsel? And then my second question is, how long is the counseling? Is this a 15-minute visit or 30 minutes, or I'm sure it depends?
It depends a little bit. It depends on the individual situation as well. Some patients do prefer to come in and talk to us face-to-face. Some of these conversations happen over telephone if mobility is an issue or if they don't necessarily live somewhere near our pharmacy. We're flexible in that regard, and it's great to have that flexibility to still be able to provide excellent patient care regardless of the situation that we find ourselves in. And to answer your time question, it can vary. You might have a customer who has done this before, just went through this procedure a year ago. They're back to do...
Did the left one, now it's time for the right.
Exactly, yep. So they kind of have an idea of what they're doing. But then you do have the first-time patients who really want to go through everything step by step, and we enjoy that. And we take the opportunity to offer Narcan to any customer who comes into the store, whether or not they're leaving our pharmacy with an opioid prescription. It's important to open those conversations and be transparent, and that's our opportunity to do so.
But I bet there's lots of folks, because you mentioned earlier on chronic pain, is that there's and sort of the cause, the root cause, right? So it may be a joint issue or some other issue for which they're receiving opioids, and now they're getting the surgery, that it's even more important to not only spare the opioids, but do this solving maneuver, the surgery, so that they don't need opioids to manage their chronic pain. So it's interesting, like, do you encounter those patients who are already on opioids and then we're doing this opioid-sparing procedure?
Occasionally, but I would say in my experience, surprisingly, it's not the majority. And I think that's kind of this shift that we're seeing in the climate. We're earlier recognizing the fact of what this is and how it's best treated, that giving opioids might not be the best solution for our patient as far as their quality of life. So we are seeing kind of a shift in perspective, which is great, I think.
Yeah.
But it also speaks to how much pain these patients are experiencing day to day. It's impacting their activities of daily living. We ask them when the pain is more severe, whether it's after activity, all day, when you're trying to fall asleep at night. And we get the vast majority of people say all the time.
Wow. Yeah, which is the importance of the surgery for people who qualify for surgery and all those other things.
And on that same note about hearing from patients, what feedback have you gotten from them after the fact? Like, has anyone called and given their opinion on how the experience went?
Yeah, I think everybody in the pharmacy has taken that phone call at one point or another.
Yep.
Just, either whether it's before or after, just, thank you. Thank you for kind of putting my mind at ease, explaining what this is all about, making me feel prepared for this procedure. And I think, the fact that we do have patients that come back speaks volumes, because that means they were successful the first time around. They're going to go on and have other procedures.
So you mentioned that you get patients from all over. Do you see people choose the pharmacy? Like, is this sort of I hate to say a marketing technique, but they say, wow, I have this great experience at the pharmacy, at Green Line. Now I want to get all my scripts here. Did you ever see that, or maybe that's hard to track?
Hard to track. Occasionally, I would say that is the case, but we're a local pharmacy, a local independent pharmacy, so our community is kind of where our business is at the moment. It's sort of, if we gain customers from all across the state, that's great, but it's something that it's important to us and a service that we want to provide, regardless if they stay with us long term.
So in terms of implementation, what was the process of getting this program started in the pharmacy, and what were some challenges?
So it started in 2017, I believe. Our owner, Christina Prakachanti, was involved in a group of healthcare providers that really saw a need to reevaluate how we were thinking about opioid usage in the state. And it was 2 different surgeons, other healthcare providers that were also involved, that designed this plan. And obviously implementing something in the pharmacy, especially something that's always evolving, is difficult. It's difficult on the best day. I think we saw that a lot, even during the pandemic, how pharmacists had to really be flexible with their day and what it meant to kind of incorporate all these new tasks into our work. And same thing with this type of program. It's something that is always evolving. The numbers are always fluctuating, how many patients we're seeing for this type of service. And it's something that's our advantage, I think, as an independent, is to be able to kind of have that flexibility, give our attention to something that matters. And I think that's what it boils down to, is you make time for what's important to you. And it is important to certainly all of us at the company, and I think it's doing a good service for our community.
Well, I think the most important thing, something that Liz and I and Chris Federico, current Rhode Island Pharmacists Association president, by the time people listen to this, maybe we'll know whether we passed a bill going through the Rhode Island House and Senate to pay pharmacists for their scope of practice. And so you mentioned patient education. It's what we do. It's what community pharmacists do. Can you imagine a time when you get to bill for that 15 or 30 minutes visit with the patients? How do you think that would change this service? Would it expand it or just justify it more? Or
I think pharmacists are in a unique position where we're constantly having to prove our value, that we're, no other healthcare provider really has been asked to do that. We've been offering this education for so long that it's just become a part of what we do and who we are to the community. So reimbursement would be great, sure, for our services, but I think fundamentally as pharmacists, it wouldn't change what we do. I think we would still provide the service to our patients. It would have to be evaluated what that would look like, how much time that would add to our day. I would imagine there'd be a component to that.
Documentation and billing, and
Right.
Is it just worth the squeeze, right? If we are constantly fighting to get paid like we are for our scripts,
right,
as it is, to try to sort of offset those things. But I think this is one example as we, think about the primary care crisis, and, again, what you're providing isn't necessarily, I would call, primary care, but it's this wonderful service utilizing the top of our license skills, like patient education, like individualized care, like collaborative care, on the phone, in person, patient-centered. This is exactly what we do. And while I would agree that maybe we don't need to keep asking for little slices of the pie as the pie gets smaller, that we can all work together, I think passing this bill at some point, hopefully this year, will just make sure that we are completely part of the team, and that the team gets reimbursed, and that these things get continued no matter what.
Mm-hmm. Yeah, I was just thinking, because I guess I can consider myself fresh out of the curriculum in my sixth year, but what we're being taught is so much more interdisciplinary than even like going from my P1 year to my P3 year. We're just learning how to work so much more with other disciplines, so I'm glad to get to experience that.
What is your interaction with the docs? Like, so I go to let's just do an example. I need a knee replacement. I go to the ortho doc. They say, your surgery's scheduled for Monday, today's Friday, go to Green Line and you'll get this pack. And then what happens next?
Typically, it comes in like a regular prescription would. We receive the packs from Ortho Rhode Island, usually with plenty of notice before the procedure
The orders
itself.
for the packs, right?
Yes, yeah. It's individualized. They're packed individually for each individual patient. There's a lot of work that goes into that for sure. There's a couple different points throughout the process where we're reaching out to the patient, checking in. There's usually that couple weeks, I would say, where it's a pretty intense, conversations back and forth about updates and how the patient's doing, any changes that might be made. Counseling portion all goes into it. So it's streamlined to a certain degree, but also very individualized. And you undoubtedly have those cases that come up where you have somebody who needs it right away. This was scheduled for immediate, and you need to adapt. And fortunately, we do have the ability to do that. So
primarily, I think this is Liz's thing, right? This is what you say you do.
I honestly really like spending time and even getting to call people. We do deliveries at Green Line, so for the people that don't come pick it up in person, they'll have it delivered, and then we'll give them a call to do the whole counseling portion. And that's happening before they get the pack. So something that we do, I'll kind of give them a visual of what it's going to look like when they get the pack in their hands. And usually they'll write it down, what I'm saying, even though we label it really well for them to understand. But I just usually like to take them through it too. And then that's a good time to go through all the questions we usually ask that Amanda was mentioning earlier. And it seems like they really appreciate that. And then also asking them what questions they have, they seem to really like, because it always brings up more questions, and then we get even further into it.
I think what's interesting too is you have a mix of prescription and non-prescription drugs, right? Or at least like omeprazole, is could be available prescription or not, acetaminophen, these things. So I think it's interesting is that this is an opportunity to say, I bet I've never asked anyone a question about acetaminophen, or I bet I've never been given information on that. It's now they get to sort of answer all those. They get to ask and you get to answer those questions.
Yeah, because not all the time, but sometimes they're already taking that medication at home.
Right.
So then they're like, do I take both? And then we can.
Yeah. Because you won't know about the over-the-counter, right? You won't.
Yeah.
Yep. So it's another important counseling point. And I think you brought up the pack. When we mentioned pack, it's all packaged in adherence packaging. So it really lays it right out for the patient. It takes all the guesswork and the anxiety of when do I take this? It's marked by day. And, I think it's important from just a reassurance position to say, okay, here's your pre-surgery pack. And this is a service that we're providing that's valuable for them when they're trying to organize themselves, getting ready for this life-changing procedure.
Yeah, we hope life-changing. And then how do they get, that's a great description. You mentioned that there are post-surgery packs too. So how does the person, so they do the pre-surgery thing, you're doing the check-ins, the prep, and they go to the hospital, they get the surgery, or maybe it's day surgery, depending on what it is. And then they leave. What's the logistics behind getting the post-surgery pack to them?
Sure. So the post-surgery packs we don't see all the time. Sometimes those are sent to their local pharmacies. They might not necessarily be packed in adherence packaging, but just for convenience for the patient after surgery when they want to go home. That's where some of those prescriptions are sent. But we do have the opportunity to see some of them that come through. And I think it's just a continuation of what we started with the pre-surgery pack. A lot of the same medications are just followed up on. And it's, we get to see that patient through the pathway itself. This opioid-sparing pathway has 4 parts. So we often see the pre-surgery part. We don't see much of the patient the day of the procedure or the hospital stay. We don't see much of them in rehab, but we may see these post-op scripts. And that's, another opportunity for us to have our pharmacist interventions. How did it go? Do you have any questions now? Where do you go from here?
Do you ever talk, there's a concept, I think we did one podcast on it called transitions of care pharmacist. And that's usually for people with chronic diseases, either that are newly diagnosed or the disease got worse, and so now we're really focused on making sure they don't get back to the hospital. Do you ever talk to pharmacists at the hospital in transitions of care, or who manage the surgical patients?
Very rarely. I know a lot of times they might be asked to bring the medications that they took to the hospital so that they have a visual cue of what the medications were that the patient took prior to the procedure, but the implementation of the plan is very streamlined there's really not a lot that we need to do after that procedure. So,
well, of course, I think that you bring up a really interesting point where in this adherence packaging, it's clear enough for the patient. And of course, it's very clear for the pharmacist because they can see what's poked out each day. But it's interesting is that if you get adherence packaging, instead of just looking at a bottle of pills that says there were supposed to be 30 in it and there are 10 left and you're like, what happened? Here you can actually see each day. So there really is no guesswork. And so,
right.
So that it's actually kind of a passive form of very accurate communication, which I think is the most frustrating thing for patients is in those transitions of care, right? And here you've got both pre-care, good communication, great counseling, and then the post-op care and involvement with rehab. So that's great.
Yeah, because no one wants to get surgery. So
No.
you just want to make it as easy as possible.
Well, these people probably do because the life-changing
yeah.
surgery, right?
Mm-hmm.
Yeah, but it's
Yeah.
still anxiety-causing, and we want to minimize all the complexities.
Yep. So Jeff and I were researching online, and we saw something about an initiative in Nebraska for pain management. It's called Iovera. It's a cold therapy that involves needles, and it's a 30-ish minute procedure, minimally invasive, but it blocks the nerves using cold therapy. And then there's also other integrative health methods. I actually took Self-Care 3 in the fall, URI students. I recommend that class highly with Dr. LeMay. But we talked a lot about integrative health techniques like massage, acupuncture, meditation, things like that. Do you hear anything about patients, about them using any techniques like that?
I'm not so sure about this particular cold nerve blocking procedure, but I know that locally our physicians do try to use nerve blocks whenever possible to kind of minimize the effects of general anesthesia, try to cut that out as much as they can. And then they're more integrative, I think, than ever as far as incorporating massage therapy, ice, relaxation techniques, all these things into recovery that may have been brushed aside before. But now we're seeking alternative options and having better patient outcomes, which I think is important.
So it's important that when we look at integrative, I think it's like integrative pain control is that it's both these non-opioid pharmacologic therapies that we've been talking about, but it's also non-pharmacologic therapies, which is what we teach in the curriculum here, for all things. It's lifestyle, it's exercise, it's all those, what kinds of exercise, what kinds of diet, making sure you sleep. All those things are sort of daily things that we all talk about and use. But if you're trying to recover from, honestly, a pretty severe insult, surgery, right? I mean, you say nobody wants to get surgery, it's because you're getting cut into, right? Under even a nerve block, it's still going to have inflammation, which leads to pain. And so controlling the inflammation, controlling the surgery, all those things are great. And some of these non-pharm things are great. I mean, I think physical therapy, right? I mean, what a great program here at URI. I can advertise all the time. But physical therapists are in, short supply because I think people are recognizing that there are really proven benefits to that.
For sure. And the more we talk about pain, the more we have discussions about it, the more we're realizing that there are so many components to pain. It's physical, sure, but there's also a mental capacity for it. There's the social aspect, all these other things that in order to take care of the whole patient and to do that well, we really need to look at the big picture.
Do you interact with families? Again, so I'm thinking like especially the post-op pills or maybe even the pre-op packs. Do caregivers pick them up? Are they involved in the counseling? Like, what's your interaction with those folks? Spouses or kids or whomever?
Occasionally families will come in together, I'd say, spouses, and we'll have that counseling session as more of a conversation because they're going to be the primary caregiver for a little while that patient is recovering. But oftentimes patients come in themselves as well, and they want to be educated. They want to make this decision on their own and on their own terms, and I think we help them to get there. Okay.
And looking in terms of outcomes, if we're able to measure that, have we seen a reduction in opioid prescriptions after the fact?
I know at one point, Ortho Rhode Island had some figures that they were able to, very quickly after implementation, see about a 60% reduction in opioid use in the hospital, that's the immediate post-operative care. So that was pretty impressive. So I think we are making strides, and to go backwards wouldn't make any sense at this point.
Yeah, I mean, the data that we reviewed in preparing for the podcast is that non-opioids work just as well. I mean, there was a long time ago, I would lecture that if you took certain combinations of non-opioid therapies, it would have the equivalent pain relief as in 5 milligrams of oxycodone, if you could acetaminophen and ibuprofen together in certain doses. And the interesting thing about that, and I did a project with a student on dental therapy, right? So dental surgeons are typically the people prescribing opioids. At least that's what we think. And then we did a study and said, no, they're really not, at least in this region. Other regions they are. And to say, well, what if we gave packs of ibuprofen and acetaminophen in the same way that you're doing for post-surgery, for post-dental care, and just literally hand it to them so then they don't have to go to the pharmacy and they still have access to counseling and all those other things. What would you think about a system like that? We talked about this like years ago.
I think there would be value in that because it would be something that, again, takes that guesswork out of it. The patient has a concrete plan for their aftercare. We're acknowledging that there will be pain, but we're going to help you. And it's not to say that we would never use an opioid. It's constant communication, I think, between patient and provider and sometimes pharmacist as far as how it's working, how it's going. If it ever starts to hinder recovery, then we'll start to take another look at it and see if they need additional pain relief. But I don't see any reason why we wouldn't be able to kind of expand this out to other areas of healthcare for sure.
Yeah, sounds like the system's working.
Yeah, it's good to hear that it's going to be continuing. Do you see it going anywhere else in the future, like adding on?
I would hope so. I think that there's been a few different programs throughout the country that are now implementing these pathways and streamlining how we think of post-operative care, how we can better prepare patients for it instead of being reactive, just being proactive about the procedures that they're going to have and our role in treating the pain, but also being educators about the safest way to do that.
So that concludes our episode on the opioid-sparing pathway. I'd like to thank our special guest, Amanda, for joining us and sharing your experiences and expertise on this topic.
Be sure to follow us at PharmD Pub Health. That's at Pharm as in pharmacist, PharmD as in doctor, Pub Health on Instagram. Connect with us on LinkedIn. Turn on post notifications so you never miss an episode. Smash that subscribe button now on any place you get podcasts, Spotify, Apple Podcasts, YouTube, or anywhere else. Thanks for listening.